You're all very welcome to the session this morning. I'm Kim Tully from Engaging Dementia. I'm the interim CEO while Sinead does a master's in psychology. So very nice to be with you today. The name of this session is Supporting People at the End of Life. Deirdre is going to be the chair, so she'll be introducing the people in a minute. Just wanted to let you guys know that if you have any questions during the course of the presentations, please put them into the chat or to the question and answer functionality. We'll take a look at them and we'll make sure that they all get answered. And we'll be recording this session as well so that you can listen to it later. And you can also listen to the other sessions of the conference that you might have missed. So with no further ado, I'd like to introduce Deirdre Shanagher, who's the Strategic Clinical Nurse Expert with Regulatory Compliance of Nursing Homes Ireland.
Thanks a million. I'm delighted to be here today and to be chairing this session, supporting people at the end of life. Just a little bit about Nursing Homes Ireland. We're a national representative body for the private and voluntary nursing home sector. We believe that the resident is at the heart of everything that we do, and never is this more important than at the end of life. I'm going to introduce our first speaker today, Irene Hartigan. Irene is a lecturer in UCC, and she's going to talk to us about communication is key, ensuring effective dissemination of key messages and new knowledge from mySupport study, and fit for context, co-designing a comfort care booklet for people with dementia. The session is 20 minutes. I'm really looking forward to hearing this, and over to you, Irene.
Thank you, Deirdre. Today I have two presentations and what I've done is I've merged them into one, and I'm just going to flow through from beginning to end. And I'm talking about our communication strategies on the mySupport study and what we've learned in communicating and exchanging knowledge between various stakeholders. And this work is part of a larger team, I suppose, our local team, which is predominantly based in Cork, and it comprises mainly of my colleagues who are nurses and geriatricians, and also our partners in this who are the All Ireland Institute of Hospice and Palliative Care, and guiding us with regard to our dissemination and knowledge activities. And then also Professor Kevin Brazil would be the PI of the mySupport project based in Queen's University, Belfast. So to begin, just an overview of this presentation is I'm just going to talk about the knowledge translation activities that we have been involved in the first year of this project. I'm going to talk a little bit about our logo and our branding and how we really had to think about getting those things right from a communication perspective with all stakeholders, and then linking this branding with our communication channels like social media and websites. And finally, then I will talk about the co-design of our comfort care booklet, which is part of the intervention on the mySupport study. So I suppose, what is mySupport about, and where is it happening? And it's happening across 6 different countries. And it was previously termed the Family Care Decision Support Intervention, the FCDS intervention. And this intervention has been studied in other countries. And the aim of it is to reduce family caregiving decision uncertainty when establishing the goals at the end of life for people with dementia. And this intervention has involved the development of a comfort care booklet, training of care home staff, and then having family care conferences or discussions with family about end-of-life care. So as you can imagine, the FCDS is not really warm and not very friendly in communicating the message across. So as part of our study and this European grant, we had to think about rebranding the study. And I will come to a little bit more detail in a while about how we came up with the name mySupport, but just to give you some overview, the mySupport study is about adapting, implementing and evaluating a comfort care booklet with regard to decision making at the end of life for families with people with advanced dementia across 6 different countries. And here are our partners that are from 6 different countries. We spread from North America to Europe, and within Europe, our partners are in the Czech Republic, the Netherlands, the UK and Italy. And we have been collaborating over the course of a year, of a 3-year project with regard to designing our intervention and making it fit for purpose. This research is also funded by the JPND, which is the Joint Programme for Neurodegenerative Disease Research. So, as part of our research, one of our work packages from the Irish group is knowledge translation and exchange. And it's very important to think about all stages of the research journey, how we can exchange information and knowledge. And we're doing this for a number of different reasons. Number one is to raise awareness about the study. Number two, to influence behavior and understandings about dementia, comfort care, the end of life, to enhance practice, and also to help with decision making at the end of life for families and for people with dementia. So when we talk about all these different ways that we exchange information and communicate, I suppose there's a number of words that are used internationally in talking about how we translate and exchange information across projects, and really making it practice ready, because I suppose a lot of the time within research we can get very much caught up in research terminology and the level that information is communicated, but also knowledge translation and exchange is about communicating to all stakeholders at all times during the project. But other words that are used in the literature when we talk about knowledge translation and exchange is terms like knowledge mobilization, knowledge brokering, technology transfer, integrated knowledge translation, and end-to-grant translation. And I suppose end-to-grant knowledge translation is probably the one that's most familiar with people, because it's about, you know, the publications at the end, but there's so many more opportunities that we need to be cognizant of during the research to get the message out to the right people. So the and I won't go into this too much. The MTREC model is a model that is recognised, and there's been a lot of work done in Ireland about this in relation to knowledge transfer and exchange. And our partners in the All Ireland Institute of Hospice and Palliative Care have developed a free e-learning course, and it demonstrates the MTREC model and shows ways of how information can be targeted at the right time with the right message to the right people. So this e-learning course is available to all and it's free, so I would encourage you to log on and check it out. As part of the MTREC model, this is, I suppose, the avenues that we need to think about for communication. And there is a number of steps that are key to this. And I suppose the 5 key steps that we need to think about is, why are we exchanging information or communication? What is the message that we're trying to communicate to our partners or to practice settings or to people at home living with dementia? Then thinking about who our audience is, how we're going to get our message across. And today is an example of how one mode of getting a message across with regard to the mySupport study. And 5 is, when is the right time to get the message out so that it meets the group that need it at that time. So as you can imagine, there's 5 avenues here, but there's a lot to consider amongst these 5 stages of the model. So planning is really essential, and there's various models that can help inform how we plan. So bringing it down to, I suppose, a level that's not going to be too overwhelming to begin with, we had to think about, okay, what is our message? What is our message within the first 6 months or the first year of the mySupport study, and who are we targeting this message at, and what processes are we going to use. As part of some of the knowledge translation and exchange plans that are out there, they will ask you questions about like, what strategies will you use? So here you can see a variety of mediums that are suggested as ways of getting information across, and those which have are very effective, which have mixed effect, and those which can help synthesis research. So I suppose a small group interactive sessions would be an example of how that is one way of disseminating some information, and then that will have a ripple effect into a larger network. Other ways of disseminating information can be through opinion leaders, research champions or dementia champions in the area, right up to various different platforms of social medias. So when I suppose you go to look at the different modes that are there to getting the messages across, there's a lot, but it's choosing the right one at the right time is important. So I suppose when we were thinking about the FCD intervention, which was part of the European grant that we were involved with and the application, we were thinking, okay, how do we get 6 countries to understand what the mySupport or what the FCD is about? How do we brand it? How do we talk about it in a way that is encouraging for people to engage with it and understand it? So we set us about an exercise between the countries and a lot within our own team, and with the help of the All Ireland Institute, of thinking about suitable acronyms for our study. And different ones that kind of came up were like ACORN, because we thought, you know, it would symbolize as autumn of life, and this then would be able to capture elements of the family care decision support intervention terms. Others that were thought about were assent was another one, you know, the expression of approval or agreement, and this would be very important with regard to making decisions at the end of life, and using the comfort care booklet to support decisions at the end of life, right up to mySupport or support me. So as you can imagine, it was a challenging process, but we felt it was very important to have a name that set well and that really kind of gave some indication about what mySupport was about. Now, there is different tools that can help you to formulate a logo or branding, and this is Acnify Me is one website that is out there, and it can help, but in this instance we didn't use it, but just for others that if they are thinking about acronyms, that's a website that can be helpful. And then there is another avenue that you need to check that the domain name isn't used. So in a lot of these cases where you can see an asterisk next to ACORN, Assent and Support Me, these domain names were already taken from a website perspective. So it meant that we were less likely to use them. When we're thinking about our logo selection, then we collaborated with the All Ireland Institute of Hospice and Palliative Care and their panel Voices for Carer, and we put the name out there to see which name was kind of sitting well with their members, and 44% of people came back and said, look, the mySupport project is the one that probably sits best. But some people did come up with other suggestions, as you can see there, like My Wishes, Support Mine and Us. And these were carers for people with dementia. So they were trying to impart some of their knowledge to us. So there was a two-way exchange of information. So here are some of the comments that people said about the logos that we termed. And one thing that really sits out is that it had to be simple and easy to use for people. And some people talk about the alphabet soup of like terminology and organizations, and it was just good to have a simple term to use. People thought it was very important to have a name that would give an indication of what the logo or the project was about. So hence we arrived at mySupport. And then we had to match this with a logo or a design. And this again, we needed to engage graphic skills here, and luckily we had the input of a designer from Design Republic, and we had some workshops to discuss, okay, what is mySupport about and how could we bring this out in a logo. And because mySupport is about a booklet, it's about people, it's about an intervention at the end of life, we figured that it was important to have these things come true in the logo design. So as you can see, the top logo here has got a book and 3 people are in a circle looking and discussing at the book. Other designs that the designer came up with then was, you know, the end of life and sun setting. Hands then were kind of another one that was, you know, the designer felt might be a suggestion. So we had to bring this true to the logo then, which was mySupport. And as you can see, we changed the O to include 3 people around in a circle having a conversation, which replicates our family care conferences. And then we had to think of tones and colors to suit this that would be soft and easy on the eye. And we thought, well, the JPND to help bring through the European funders, and that will use their circles around the people and the intervention, which is the booklet, to demonstrate across the mySupport. So when you look at the mySupport logo, there's actually a lot of reasons and meaning for each part of the logo. And then we had to think about how we're going to share the information and how we're going to communicate out the activities of mySupport over the course of the 3 years. So we have launched a website last year in November, and this was launched at the All Ireland Institute of Hospice and Palliative Care conference by Professor Brazil. And the website I will come to later, but it's up and running and you can access this through the web. We also set up a Twitter account, and again, we're able to use the same branding, mySupport Study, and use the logo. So people will be able to readily identify with mySupport when they logged onto various platforms. When we look at the blog, we were able to, or the website, we were able to post up blogs as another way of communicating out with various stakeholders. So we have some blogs up there with regard to end of life across our different partners, and some of the subjects talked about in lay speak. This is the mySupport Facebook page, and in this as well, this is where we use as another medium of communicating out information on the mySupport project. So when you look at the timelines over the first year, the name came in September 2019, right through to the logo development, to the Twitter, to the website, and then to the Facebook. So there was a lot of work in setting up these channels so that over the next year 2 of the projects that we can now capitalize on these mediums, or if people want to look at activities with regard to mySupport, that they can check out these websites intermittently and when they require them, so at a time suitable for them. So just to recap on the knowledge translation model was MTREC. There has been a lot of planning done around this, and as they say, if you don't plan for it, it won't happen. And we would encourage researchers, healthcare staff, carers, people with dementia to log on and read about the mySupport study and ways that it can reach people to help ease the process or the transition across the various stages of dementia.
Sorry, Irene, just to get you to move on to the next presentation, if that's okay, just because of the time.
Yeah, so as part of the intervention then is the Comfort Care booklet, and the Comfort Care booklet was originally designed in Canada, and this booklet as part of the European grant now needs to be translated into an Irish version, also a Dutch version, and so on as per our other partner countries. So here is the original authors in Quebec, in Canada, of the booklet. And this is how we've been working with our Irish team that are listed there. And very importantly, a patient and public involvement group in designing the comfort care booklet. So it's fit for an Irish audience. This is the stages of redesign of the booklet, because as you can imagine, there was a booklet to begin with from as part of the original FCDS study. And we have now redesigned it to include the branding of mySupport. So within this, there is different stages of activities that we were able to engage with our PPI groups. And I suppose you've got to remember that COVID has hit over the last 6 months, so things have really changed. So we were lucky, though, that we had a meet up with our PPI group just like it was literally on the 9th of March with our group. So we had that chance to meet people that had expressed interest in joining the mySupport advisory group. And we were able to do an icebreaker activity with them about, just a little bit about design and how headings in the newspaper, would match the pictures underneath them, a little bit then of mounting it on a background to think about little differences with regard to color, and why did you choose that color, and maybe what does the message communicate when we put a picture with the heading from a newspaper. So this exercise was really useful to as an icebreaker for our group, but also to kind of get us into the idea of design and thinking, and what we see when we pick up pieces of information, leaflets, booklets. So there was a period then of 6 months where we were over and back with our 2 PPI groups. One was a local group, and then another group was an online group, which were spread nationally. And we met with them at various stages to talk to them about the look and feel of the comfort care booklet. And what was useful about this is we got some very important information about, the level of detail within the comfort care booklet, the volume of information, how the information was communicated. And all this feedback was taken on board when we were editing, because we didn't have full control to redesign the whole booklet, but we had to edit it and make it fit for purpose as part of the mySupport study. So we would ask individuals, okay, whether or not the booklet should have more pictures of people, whether it should have more pictures of nature, or whether it should have pictures, of symbols that were, illustrations. And what was discovered was that here, from exercises and activities that we would have done at various time points with our PPI groups, was that they gave us their feedback with regard to what they liked. And when you look at the third column here, and it's got the picture of nature, and you think nature would be very calming, some participants felt that, oh, the daisies, does that mean I'm going to be pushing them up soon? So it was very interesting to see the different perspectives that people came with regard to the images that were used along the way in the booklet. And this is very important because the booklet is talking about a sensitive subject, end of life choices and providing comfort care. And it was important that as they turn the pages, that there's comfort in what they see as well as what they read. So this is another exercise we did with our group. We sent them, a little Google Forms questionnaire, thinking them, okay, did you find the image, informative? Was it reassuring? And between the information that we got back from participants, it was kind of decided, look, the versions with people are definitely kind of what people gravitate more towards, and some with images. But I think a lot of people also liked the illustrations, which, are symbols, because I suppose they were open to, whatever interpretation they needed to take from it, and that they weren't necessarily, shocked by, maybe a clinical image of a stethoscope or a white coat. And there was a lot of discussions about those, but in the interest of time, I'll move on. The other thing within the comfort care booklet that's important is that there's 39 questions that were part of the original booklet, and we had to twickle these down to 15 with our PPI group. So we had to think about, okay, what questions were important, and what questions would be useful to have in there that might stimulate discussions and conversations during the family care conferences. So we divided up into various sections, and people came back, and here on the right hand column you can see what people's responses are. Like, we were saying, like, how much information do we put in about confidentiality? And yes, people said that yes, confidentiality is important, and it's good to establish this at the beginning of the booklet. Other people talked about the positive experience within how do we ensure a positive experience, and people said yes, that's important for the person, and it's not just about lying in bed for the final day. So they were out of the 39 questions, it was a difficult task to bring it down to 15, and a lot of people came up with other questions that we hadn't thought about then, which were more related to the practicalities of managing dementia at the end of life, so like managing hallucinations and different things like that. So the question prompt list was an exercise that was led out by our Dutch partners, but we have arrived at consensus of 15 questions across all our partner sites. So just other little design features that we have added into the booklet that weren't there before, and you think, well, these are kind of pretty simple, but I suppose when we're a team of, like, yes, we did have a graphic designer on board, but we're a team of nurses and doctors and researchers working on the booklet. This is where really our patient and public and advisory group really helped as well with making us think, well, how can we make it more user friendly? How can we really make it fit for purpose? So little things like putting in, like, the bubble icon to now's the time to stop and think about this question, or to think about this section in the booklet. Just the two heads then was another one to think about. Let's have a discussion about this, or if the person wants to write notes. So we've dotted these throughout various stages of the booklets, and this is something as well that we would have had from some of our online learning activities that we've had to jump into over the last wee while. So again, you can see here, when we talk about cardiopulmonary resuscitation, at the end of life, again, there's section, with regard to, let's stop, let's think, let's jot down some notes for participants. So this is the final stage, I suppose, the prototype. This is what we to begin with in 2008 was the family care booklet with flowers as the first image with regard to the look and feel. And based on the work we've done over the first year, this is now what the comfort care booklet it looks like, and will be ready for implementation into our sites over the next 6 months. This is one of the symbols that's included in the booklet. And again, this is the symbol of birth, death and life from the Irish Hospice Foundation. And again, that's a known sign among healthcare professionals, and that then automatically, just prompts people, that for quiet time, respect. So the importance of symbols as well was very, very important in this exercise. So in conclusion, some of the things that we found as part of these exercises with our PPI groups is that, number one, language is important in how we engage stakeholders, and that the message is clearly and succinctly communicated. This morning, earlier presentations, there was a lot about, co-design and with various activities for people with dementia. And this was very much evident as well within this process. Like everybody came to the table between our researchers, our multidisciplinary team, our carers of people with dementia, to really help inform and develop the comfort care booklet into its current format. Involving the PPI group is very much part of this process, and hopefully will continue for the next 2 years of the projects. And maybe the other thing as well, just to think about, is how we can ease understanding using different images, icons, pictures to illustrate what it is we're communicating to our various audiences. So just as a final, and this is something that might be important for people, is engaging PPI is very important, and we're seeing more of this now in research. And I suppose this morning there was a lot of talks around, you know, different ways of doing this through dance, through arts, and currently, as part of the knowledge translation on this project as well, we are preparing a promo video on the mySupport project, so that'll be coming soon. But in the meantime, Curum, who are the Irish Film Festival, is happening on the 5th of November, and there's other mediums there with regard to involving PPI and communicating across different life-limiting conditions and neurodegenerative conditions. So sorry, Deirdre.
Yeah, I was just gonna jump in there. Irene, I know I personally would like to hear a little bit more about the PPI side of things. So we might come back to that. I see there's a question coming in at the end as well, but just in the interest of time, I'll just say thanks a million for now, and I'll introduce our next speaker, if that's okay. So our next speaker is Kate Steele, and Kate is the National Development Manager, Residential Settings with the Irish Hospice Foundation. And Kate's going to talk to us about CEOL at end-of-life care for people living with dementia. She's going to be followed by her colleague Majella Sweeney, who's a Director of Nursing in Archview Nursing Home in Donegal. And Majella is also going to talk to us about CEOL at the end of life for people living with dementia. So it's my pleasure to hand things across to Kate.
Thank you, Deirdre, and thank you very much for inviting me here today to speak about supporting people at end of life and people living with dementia, and the Irish Hospice Foundation and our programme, which is called CEOL, Compassionate End of Life for people living with dementia. As Deirdre said, my name is Kate Steele, and I will be the National Manager within the Irish Hospice Foundation, and with a team developing and implementing the CEOL programme. I'm just going to give you a little bit of background to the Irish Hospice Foundation. And we were, I suppose, established in 1986, and our vision is to have an Ireland where people experiencing dying, death and bereavement are provided with the care and support that they need. And our mission is to work towards the best end-of-life care and bereavement care for all. What we do, we work across 4 real departments is kind of what we say. We fund, deliver and support a range of programs and services across the following: bereavement, education and research, advocacy and public engagement, and healthcare. And that's where our CEOL, our Compassionate End of Life programme, would sit. Just a little bit on stats, and I'm not going to go into too much in detail, but I mean, we kind of say, or we would have up to this year, and I do know with COVID, things would be quite different, but we say around 7,500 on average people would die each year in residential care settings. This kind of graph just shows us that of the people that die, 40% would die in hospitals, general hospitals, but 23% die in community nursing homes, nursing homes or community nursing units. And again, that's just to put things into context. We have an aging population, and we know that. The ERSI in 2017 estimated that by 2030, there will be 1.1 million people over the age of 65. We have 55,000 people living with dementia in Ireland. And again, they estimate that 63% of people with dementia are living in long stay residential care centres. The average length of stay in nursing homes has reduced from 4 years to just under 2 years. And again, the Department of Health's review of the Fair Deal acknowledged that in 2015. And we are living with more, I suppose, acute care requirements, more kind of illnesses, comorbidities. As we've said, and I said earlier, we estimate that 7,500 people die each year in residential care settings. Again, that is not taking into account, and we will talk about, or I will talk about COVID and the effects it has had on this year in supporting people at end of life in residential care settings in nursing homes. So again, HICRA would, I suppose, recognise that each resident continues to receive care at the end of their life which respects their dignity and autonomy and meets their physical, emotional, social and spiritual needs. So I'm just going to give an introduction to the CEOL and the Compassionate End of Life programme. As Deirdre said, my colleague Majella, after my presentation, she will give you the lived experience of implementing CEOL and providing end of life care in nursing homes throughout this year. So CEOL is a continuous quality improvement programme, and it supports all nursing home staff. And when we say all nursing home, multidisciplinary, household, catering, nursing administration, whatever settings or sectors are in the nursing home should be represented. And it's supporting them to ask, how are we doing? Can we provide better end-of-life care? Can we be more compassionate when we're delivering end-of-life care? And I suppose for us, continuous improvement begins with a culture of improvement for the residents, the families, the staff, and the care centre. So again, we've said CEOL, it enables individual and group reflection and learning on the end-of-life care that is being provided. And most importantly, it is built around the needs and preferences of each individual resident, incorporating their end-of-life care planning. To support staff to provide the best end-of-life care for people living in residential care centres. Enable and empower staff to continuously review, reflect and improve on the end-of-life care they're providing. And to support staff with self-care, grieving for residents and providing peer support. So each individual nursing home, if and when they become involved in the CEOL programme, they establish a CEOL group. And again, the CEOL group, they're your champions, they're your drivers. They have responsibility for driving, developing and changing end-of-life care from within the centre. And again, multidisciplinary, any aspect or every aspect should be represented on that centre or on that CEOL group, from household, catering, nursing administration, medical GPs. We've had 1 or 2 GPs that have sat in on some of the training, to broaden it out and to look at end-of-life care in the care centre. That CEOL group will look at and develop a vision for end-of-life care. And this vision is residents and staff vision. It's a whole inclusive vision for what, if I were a resident in this nursing home, what would I want for end-of-life care? You establish CEOL reviews, and we'll talk about those a little bit further now, but a CEOL review after the death of each resident to support staff to review care provided and identify areas for change. You also invite feedback from bereaved relatives and friends. So you're going to get their experience of end-of-life care that was provided. And then it's about implementing quality improvement initiatives, and also about recognizing what is working really well. What are we doing really well that we can bring to a next resident who is approaching or is at end of life, that we can ensure that they have the best end-of-life care. We talked about a CEOL review meeting held following the death of a resident. Creates a collective space for staff to remember the resident and acknowledge the loss felt. Provides an opportunity for staff to review and reflect on the care they provided, and an opportunity to support colleagues with self-care, grieving for residents and providing peer support. A lot of the research and feedback we get from centres that are doing it would actually tell us that a CEOL review, what it does, it provides a support structure for staff. It provides closure. So staff get to that time to remember a resident who has died, and it gives them a sense of closure. Individual reflective practice. So it's an opportunity as an individual to look at the care that we've provided. Importantly, collective reflective practice. So as a group as well of staff, multidisciplinary staff, how did we provide end-of-life care? Was it to a standard that we would want for ourselves? Learning and sharing. So it's an opportunity to learn and share. And again, most importantly, an integrated team approach. So these are some of the quotes we would have and feedback we'd have got from staff. We take time to remember the resident, we pause. Professional, personal learning. We reflect and remember the resident collectively. And the review gave us closure and a sense of being valued. There is a bereaved relatives questionnaire. So 3 months after the death, the CEOL Group, somebody in the CEOL Group will have responsibility for sending out and inviting families. They may not wish to, I suppose, respond, but if you send that questionnaire, you invite families to give their experience of end-of-life care received. The CEOL Group, which we had established earlier, they meet regularly as a team to discuss feedback from the CEOL review meeting, the CEOL postal questionnaire, so feedback the families have given. So they look at I suppose, both the feedback and they look at, well, what worked really well? What areas could we have looked at? Did we need to look at communication a bit more? How is pain managed? How as a team did we work together? Was there communication across the board? And it's key to be able to kind of look at that, reflect and take the learning and bring it towards the next person, next resident that is approaching end of life. And importantly as well, there is an element of change and change management and feeding back to staff and bringing everybody along. So it is quite an interactive, continuous kind of quality improvement program. We had established, and we have established networks where we would, the Irish Hospice Foundation, host networks 3 times a year in different regions. And these were really invaluable learning platforms where staff got together. So some staff from the centres would come, there was shared learning, there was peer support. Importantly, there was continuous professional development. We would link in with palliative care, clinical skills. We'd provide ongoing support and training. Obviously, due to COVID, we haven't been able to host those. So we moved to CEOL Connect, which was, or initially was, connecting the CEOL sites so that they could still meet, they could still support each other. And then now we're doing virtual CEOL networks once a month. It is an area that, again, I suppose we're learning ourselves. We're linking in palliative care, so there's training going on. The connecting and the peer support is an area that we'd love to maybe focus a bit more on, because that invaluable, I suppose, opportunity to meet your colleagues, to learn what's going on in your centre, to share. It's harder virtually, and we all know that, and we're all learning how to, I suppose, do our Zoom presentations and do our Zoom events. And that's an area we'd love to, I suppose, focus on more. Now, the challenges, and I know you're all well aware of these because you've lived and you've experienced them. But challenges for nursing homes, social distancing, limited, I suppose, gatherings, and how that has affected nursing homes. Using personal protective equipment. Visiting restrictions, again, and never more so difficult around end-of-life care, and trying to support families to be there within the social, I suppose, within the public health measures has been very difficult. Communication barriers, again, communication around end of life, around when somebody might be approaching end of life, you're using your personal protective equipment. I know, and we've supported many campaigns around of, you know, having tablets, other areas, you know, other communication methods when families can't be available or can't come into the nursing home. Family members unable to be present when a loved one is dying. Again, being unable to attend funerals. And again, that can be for the resident who a loved one may have died outside from home. It can be for the staff. It can be for, you know, for families. Really, really difficult in the social restrictions that are in place. Lack of access to social supports for residents. Having to grieve on your own. And I suppose importantly for staff, moral injury. For staff, not being able to provide the care that you would want. And at the end of the presentation, we have a quote from a staff member, and I suppose that sums it all up in all the end-of-life care planning and how we can, during COVID, provide end-of-life care. Challenges for people with dementia living in nursing homes, and I suppose towards end-of-life care. So people with dementia may not fully understand the significance of and the need for isolation. A carer wearing full personal protective equipment could be frightening to a person with dementia. Communication may be a challenge, and staff may have to rely on signs rather than symptoms of COVID-19. And I think we're all aware at the beginning that, you know, the atypical signs or symptoms for COVID were different for older people. But again, I would refer back here to staff and you knowing your residents and knowing when something was off, when appetite was gone, when they weren't themselves, and being able to actually, you know, act on that to the benefit of the residents. I suppose residents with dementia, they lost the face-to-face contact with their family members. Group activities in nursing homes were stopped, and all this led to increased social isolation for people living with dementia. In May, I suppose a few months into the COVID pandemic, we did a small CEOL survey internally within the CEOL network and the CEOL centres. We used a monkey survey. It was a 5-question survey, multiple choice and open text options. And it really was designed to us to get information from us. What can we do from the CEOL programme to support you during COVID-19? It was open for 21 days from the 7th to 29th of May. And I suppose we disseminated it through our CEOL database and emails. And we had 24 responses. And we utilised monkey survey software to analyse it. So our first question really was, what have the biggest challenges been for you and your colleagues since COVID-19? And again, and I'm sure you're all well aware of this, staffing levels and cover was a major issue. Visiting restrictions, and obviously visiting restrictions were going to impact on end-of-life care and supporting residents and supporting staff. There was stress and anxiety for staff. There was also a challenge was I suppose the updated guidance. There was a lot of guidance. I think everybody was learning on the spot about COVID, and I suppose policies were changing and supporting centres because there was continuous, I suppose, sea of emails and guidance coming. Obviously, the CEOL reviews were paused. And again, that would have gone back to the staffing levels, cover, it was essential care that was to be provided, areas, even just the social distancing and getting a group of staff together to review, all this needed to be looked at. Infection control was another issue as well, obviously, in relation to COVID and supporting the centres, supporting everybody, and I suppose training that was coming down, and then supporting families again. So they were the main areas that this nursing homes would have found challenging. Additional qualitative responses we got were obviously managing a COVID-19 outbreak, communicating with new clients, death in hospitals. And I think staff struggled a lot when residents were transferred and death occurred in hospital. End-of-life care challenges with COVID-19, fear, hospital transfers, the impact all of COVID was having on residents, using PPE, how that affected their daily interactions, and especially then around end-of-life care, resident safety, and time. Time was a major challenge for staff in nursing homes. So then we asked, what supports do you want from CEOL? What can we do to support you? And what centres were looking for was information and support that they could give to families. They wanted regular updates on the guidance and policies that were being disseminated. They wanted support about the CEOL reviews, staff care and support, continue with the webinars, and obviously support around end-of-life care. Additionally, support, advice and information for families. So, and I'll show you towards the end, we developed a care and inform resource, and we were very fortunate to get support from the HSE to develop a bereavement support line. And I have more kind of information on them at the end. We continued with our emails, our updates, revised, chain, any of the guidance. We would keep centres informed, and we would focus on staff well-being in relation to anxiety and stress that staff were experiencing. What topics would you like to include in our CEOL Connect and our CEOL Virtual Networks? Self-care and staff well-being came up really, really, really high. CEOL reviews, how we could look at and how we could support with CEOL reviews. And what I will say, and I will be honest here, during the initial COVID-19, I suppose, crisis and outbreak, CEOL reviews were paused. Staff focused on essential care. They focused on supporting the residents and the staff. And the families. So again, now centres are starting to look back again and going, well, how can we actually now do reviews? What way are we going to go around it? And Majella will talk a little bit more about this actually after me. And I see Deirdre popping up here, so I might have to move on a bit. We continued with the resources and the guidelines. And our next then, we also asked, what supports would you require through our CEOL Virtual Networks? Specialist palliative care support came up a lot, and we were very fortunate to have, I suppose, really good support from the local community palliative care services, but also the National Palliative Care Programme and Francis Nevin. So for each of our networks, we would link in a piece on either the non-pharmaceutical approaches to palliative care, recognising death and dying, the palliative care needs assessment. So we would incorporate all of them. We would also focus on staff well-being, and we would do a piece at the end towards supporting staff. Opportunities to share. Yep.
Just
no
in
worries.
the interest of time, we
perfect.
I flicked.
No worries. I flicked through these last few slides. So again, opportunities to share with colleagues, and we would also always the latest updates that are changing all the time. The latest guidance. We would continue to kind of, I suppose, highlight areas that were relevant to nursing homes. This is a quote I'd mentioned earlier. We have spent years developing our residents' end-of-life care plans. To have all the information about their preferences in end-of-life care, and now we are unable to deliver them or to deliver their end-of-life care as they wished. And I think that kind of sums up, I suppose, how difficult COVID-19 was initially, and how nursing homes struggled to, and I think some of this goes back to that moral injury of how, of wanting to provide the best end-of-life care, but being limited with the social restrictions and public health measures that we're in. I'm just going to say a few other things we developed was when someone you care about is dying in a nursing home, what to expect. It's up in our Care and Inform. That was designed to support families. But again, I think staff in nursing homes, it's a very good resource, because I always think we don't know the experiences that people have had prior to supporting somebody who has died. And there's an expectation, even as staff members, that we should know the dying process. Whereas I think a lot of the time, we don't, and our past experiences shape that. So this was a general guide and non-COVID related, just when someone you care about is dying in a nursing home, what to expect. We have a Care and Inform hub, which we spoke about, different sections, caring for others, healthcare resources, loads of information there to support centres. And our bereavement support line. And what I'm going to say about this is it is open to everybody, not just family members, but as staff. We can access this. We can get supports for us if we have lost someone, and that someone can be a resident that you have cared for a number of years. So please avail of this service. It is there to support us. And again, thank you very much. I'm going to stop sharing now and hand you over to Majella. And I'd like to thank Majella for agreeing to, I suppose, share her experience. It's the lived experience of implementing a CEOL program while also providing end-of-life care in a nursing home. So I'm going to stop sharing now. And if you have any questions, put them up in the chat. We'll be more than happy to answer them at the end.
I would like to thank you, Deirdre, and thank you, Kate, for asking me to share our lived experience in Archview Lodge with you all today. Thank you all. My name is Majella Sweeney. I'm the Director of Nursing here in Archview Lodge, nursing home in Letterkenny, County Donegal, for a long number of years. We're a 30-bedded, family-run private nursing home. We have a third of our residents with a diagnosis of dementia. We usually have around 10 residents from the 30 with the diagnosis of dementia. We received training from the Irish Hospice Foundation and joined the CEOL Group in 2016. Through the CEOL programme, we are continually improving the quality of end-of-life care given to our residents. Family and friends feedback is a very important aspect of continual improvement. Thankfully, we have not experienced an outbreak of COVID-19 here at Archview Lodge yet, but we have experienced the challenges with caring for residents with dementia during COVID-19 pandemic. The first challenge we had was the lack of physical contact for residents with their loved ones. Residents with dementia really need face-to-face contact with their loved ones. In Archview Lodge, some of our residents would have daily visits from their families, and indeed the families would come to visit them at meal times. They might come for the afternoon tea or the evening meal to assist their residents with their meal. And this makes the families feel really in contact and feel that they're helping to care for their loved ones, even if they're in the nursing home. The second difficulty we had was engaging residents with dementia in FaceTime calls, Skype, etc. For example, we have a resident with advanced dementia who walks the corridor quite a bit. And to try and get this resident to engage in FaceTime was a challenge. Sometimes it meant that the staff walked the corridor with the resident holding the tablet for her to engage. And while she might not have engaged totally, the families were happy to see her, family members were happy to see her, to see that she was still walking the corridor, to see that she was engaging in with the staff, and to see that she was able to still laugh and be content with them. Another challenge for us was seeing further deterioration in the resident's condition and explaining this to families. When families come and have a face-to-face visit with their resident and have a face-to-face discussion with the staff, it helps them to see the deterioration and to understand it. So we found that was an extreme COVID-19 pandemic. So that gut-wrenching feeling, knowing a resident is in the end of their life and wanting their family to be with them was difficult for us as well. Helped us advanced care planning for end-of-life care. Assessment is done on admission by person-centered care, and end-of-life care plan is developed encompassing all of the residents' previous personality, their life story, their wishes, etc. Any wishes that the resident or indeed the resident's family may have are documented at this stage and carried out during end-of-life and dying phase. Anticipatory prescribing for end-of-life care, although not always required, should be in place so that if the resident presented with any terminal symptoms, such as pain or agitation or secretions, then the medication to relieve this is already prescribed, and so we can continue to keep the resident comfortable. Having this care plan in place prevents panic and confusion for families at the stage and allows staff to focus on the residents' needs and the needs of the family. Deaths of residents with a dementia diagnosis in Archview in 2019 and 2020. In 2019, we lost 8 residents with a dementia diagnosis. So far this year, 2020, we have lost 5 residents. Of these 5, 3 were during the restrictions due to the COVID-19 pandemic. In all of the 3 deaths, family were present with their loved ones at the time of death. All 3 residents were identified as being in their final weeks and days of life, and family were allowed to visit them in the weeks and the days leading up to their death, not just when they were actively dying. For example, one of our residents, her condition deteriorated in April, and we facilitated the daughter to visit her at that stage. Her condition plateaued for a few weeks, and her condition deteriorated further. At that stage, we allowed her 2 daughters and 4 sons to visit. And on the 3rd occasion, when her condition deteriorated and she was actively dying, her 2 daughters were facilitated to spend the last 24 hours with her, and her 4 sons visited her in turns. And because we knew her personality and had the advanced care plan in place, we knew that she loved people and especially children, and she benefited greatly from doll therapy in her dementia. So we knew that would be a wish of hers to have her family all around her. And so they were all around her bed. They prayed the rosary and they said a special prayer that she had taught them when they were young. And she took her last breath and passed away. this is a definition of compassion that I thought was very appropriate. Compassion can be defined as sympathetic consciousness of others' distress, together with a desire to alleviate it. I just thought that was nice. I'll talk a little now about how we kept everyone safe during these visits while in lockdown. We purchased portable hand washing stations and placed them at the door nearest the resident's room, and the visitors were brought in the same door, the door nearest their resident's room. We provided PPE stations, and PPE was worn by all who entered the building, and staff, if needed, showed the visitors how to put on the PPE. Risk assessments were done on an individual basis. Visitor screening forms were completed prior to the visitor entering the building, and this included temperature checks. And I must add in there that staff played a large role in this as well. Quite a number of our staff are long-term staff and have been here for almost 10 years. And so when I was developing a staff program, training program for the staff a number of years ago, hand hygiene and infection control was done annually. But after an outbreak of norovirus 4 to 5 years ago, we increased that to twice a year. And so we feel here that that was a benefit to us. And finally, prayer. We all prayed very hard here, and the residents feel that that played an important part in keeping us all safe during COVID-19 pandemic. I'm just going to show you a few family feedbacks. Kate mentioned the importance of the CEOL Group getting family feedback, and I'm just going to show you a few that we have received. The first one is from the brother of a resident that passed away here, and it says, "Thank you for the loving care you and your staff showed towards Frank while he was in Archview. It was a great source of consolation to have seen the respect and professionalism with which he was treated. We, his family, could not have asked for more. Everything was done so calmly and efficiently that you made a difficult time so much easier for us. The fact that Frank had neither pain nor discomfort towards the end is a tribute to yourself and your staff. Thank you once more for your kindness to Frank and also to us." The second one is based on the feedback, the CEOL feedback questionnaire. And the question is, were you told in a caring and sensitive manner that your relative was going to die soon? Yes, staff before she deteriorated further, and also when she was dying. The next question, how well did staff meet your relatives' end of care wishes? Excellently. Mummy was anointed and this was very important to her. The next question, did your relative experience pain at end of life? None of the time. She was so comfortable. And the third one is the feedback from the resident that I've just spoken about. Thank you all so much. During these tough times, we all dreaded not being with Mommy at the end. We felt so safe coming into your home, temperature checks, PPE, hand washing. Words cannot express the gratitude we have for you all. Mommy loved you all and you kept her happy and content right to the end. We are so grateful we were with her when she passed away. And that resident was with us for 5 years, so we miss her still a lot. So this screen is the CEOL death reviews during COVID-19 pandemic. The CEOL death reviews have become an integral and invaluable part of our end-of-life care. The reflection and remembrance involved in the death review not only improves future end-of-life care, but also allows staff to grieve the loss and reflect on their relationships with the resident that has passed away. We have all disciplines of staff involved in our CEOL group. It was very important to all staff that these death reviews would continue. And so during the pandemic, we needed to change the usual format of the CEOL group to comply with the regulations, but also to continue with them. In normal times, we have 1 hour death review per resident and only 1 resident on that occasion. But in order to reduce the number of meetings taking place, we decided to do 3 death reviews at a time, allowing 1/2 hour for each review, adhering to social distancing. And while this facilitates us to continue the death reviews, it's difficult for staff to change their focus from one resident to another. And so as soon as possible, we will revert to the 1 hour per death review per resident.
Majella, I'm sorry for interrupting you. I'm just conscious of the time.
Yeah, this is just my last screen now, and it's just a quotation that I thought was nice. Because someone we love is in heaven, there's a little bit of heaven in our home. Thank you very much. Thank you.
Thanks a million, Majella, and thanks everybody, to Irene and to Kate as well. I'm conscious of the time. We're 13 minutes past 12. I can see in the chat box that both Irene and Kate have answered the questions as they've come in. So I suppose I'll just ask one question of each of you, if that's okay. Irene, I was wondering if you could tell us a little bit more about working with service users. You mentioned a good bit about public and patient involvement, and maybe some of the challenges or barriers and considerations that you think are important.
It's been an amazing experience. We've learned a lot from our carers that have been involved, and they're all new to the project. We just recruited them at the start of the mySupport. And COVID has really changed things, as everybody knows and has mentioned. But I suppose some things that happened in the positive of all of this was, you know, those free postcards that came there early on in COVID. Like, we were all working from home, and, you know, managing all that comes with that. But we decided, okay, we don't have much resources. We didn't have a lot of, you know, money at the beginning with this project. And, you know, it was, things are protected on other things. But during that time, it was like, how do we keep in touch with our PPI groups? Just let them know that we're thinking about them. So we use the postcards to write into all our PPI groups, and they were just so delighted, you know, that we just touch base. Hello, how are you? You know, we're thinking of you, and, you know, when things will settle, we'll you know, keep in contact. We had a WhatsApp group, but it's amazing, like, some people don't necessarily want to engage in a WhatsApp group. So it's like that, different mediums for different people, and you kind of have to cover all avenues, and it is time intensive, but it's definitely worth it.
Yeah, brilliant. Kate, I wondered if you could tell us a little bit more about, or maybe it's a bit too early to say, you mentioned in the survey about the psychological support for staff. I just wondered if there was anything you could expand on that a little bit in terms of supporting staff in nursing homes post COVID-19.
Yeah, I think that's an area that is going to actually have to be focused on a lot more. And I think it was recognised, and a recommendation was made in the nursing home expert panel review from the nursing sector that went on, is the support the staff are going to need going forward, because it has been a very, very, very traumatic, I suppose, experience for everyone. I suppose there's the end of life, and there's providing support to the residents. but then there's also that working in a nursing home environment where there may be fear if I bring it in, well, you know, and the guilt you may have with it. There's working in an environment where you feel, oh, what if I get it and what if I bring it home? And then there's quite a number of people that actually who contracted I suppose COVID and are living with kind of long-term health implications. And I know there was 2 different nursing homes I had spoken to, and staff were saying how staff members may have been off for a few months, that they were coming back, but even coming back, you know, like, I mean, physically they were still kind of, I suppose, limited of what they could do, but also there was an anxiety and that stress. So there was a need to want to come back, to get back to some normal life, but also that kind of I suppose the worry and anxiety of their ability and what they could do. So no, it's a major area going forward, and I think the government, we need to be focusing and calling for proper supports and help for staff in nursing homes. Well, not just nursing homes, it'll be all healthcare settings.
Absolutely. I'm just conscious of the time, so thank you all once again. I know I personally could stay here and chat to you all about it. They were fantastic presentations. I suppose I just want to acknowledge the role of Engaging Dementia as well. It's been a super 2-day, well, 1.5 days so far. NHI are delighted to have been involved in the advisory panel, and well done on a super conference, and I hope you all enjoyed the remaining presentations today. So thank you all very much.
That was an excellent session. I really enjoyed it. I just want to launch a poll for the attendees before we end the session so we can get some feedback. So thanks so much, Deirdre, Kate, Irene, and Majella. Really enjoyed those presentations. Again, this is going to be recorded for everybody, and we'll be letting you know when it's available. Looking forward to seeing you guys at the rest of the sessions the rest of the day, and mind yourselves. Thanks so much.
Thank you.
Bye.